for today's webinar on influenza 2016-2017 updates. This webinar is sponsored by the Illinois and Chicago Department of Public Health. Today we are joined by Dr. Joseph Bresee from the CDC for the first part of the webinar and Serese Marotta from Family Fighting Flu for the second part of the webinar. I apologize in advance for the delay, but I hope this works out now for us. Participant phone lines are muted. This webinar is being recorded finally. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel on the right-hand side of your screen, and Dr. Bresee will be able to answer them at the end of his presentation. After this webinar, you will receive an email with a link to the recording of today's webinar, as well as PDF to the PowerPoint slides. Now, I'd like to introduce Dr. Joseph Bresee. He is currently the Chief of the Epidemiology and Prevention Branch. He is a captain in the U.S. Public Health Service. The EPD branch is responsible for conducting influenza surveillance, working to understand influenza disease burden, helping to derive appropriate vaccine and antiviral use policies to prevent seasonal influenza, detecting and preventing avian influenza and pandemic influenza, and providing technical expertise to global public health partners. He has led the branch since 2005. He also serves as co-director of the Partnership for Influenza Vaccine Introduction based at the Task Force for Global Health, which seeks to accelerate the use of flu vaccines in low and middle income countries through developing public-private partnerships. Dr. Bresee trained at Baylor College of Medicine in Houston and then completed his pediatric residency at Children's Hospital and Medical Center at the University of Washington in Seattle. He joined CDC in 1993 as an Epidemic Intelligence Service, EIS officer in the influenza branch. From 1995 to 2005, Dr. Bresee first served as a staff epidemiologist and medical officer specializing in viral gastrointestinal infections and respiratory infections. Subsequently, he was promoted to the epidemiology team lead. His research and public health activities focused on rotavirus disease and rotavirus vaccines, and he worked to ensure the rotavirus vaccines were available for children in both the U.S. as well as those living in developing countries. He has authored more than 200 peer-reviewed papers and textbook chapters. Please join me in welcoming Dr. Bresee.
Hey, thanks very much, everybody. And since we're getting a late start, I'll skip a few slides as we go along. I want to make sure you have time for Ms. Marotta at the end, and so I'll go fairly quickly, but you can ask questions if I skip something that you're interested in. So what I'm going to talk about today is I'm going to review a little bit of last year just to put context for this year, and then talk about what we're seeing this year in terms of flu, and more importantly, what the vaccine policies are changing to this year that in ways that may be of interest to you. And so let me start with a summary of last year. First, as you can see, this is a slide of the laboratory data from our surveillance in the U.S. each year, and the histogram is just a weekly number of samples color-coded by the type of influenza. The orange bars that occupy most of the volume of this graph are influenza A, H1N1 viruses. And as you can see, there was a predominant H1N1 year last year. That was interesting because it was really the third year or the second year since the pandemic emergence of this H1 virus for it to be a predominant strain, which is a little more than we saw in the 20 years or so leading up to the pandemic. But mostly an H1N1 year. And the other thing strange about this last year, a little unusual at least, was it was a little bit later than usual. The red line you see in this graph, and this is a graph of outpatient visits associated with influenza-like illness, as a very sensitive indicator of both the magnitude and the timing of influenza in the United States. And if you look at this, the peak of it occurs really in late March. It's about the latest peak we've had in the last 30 or so years of influenza. We have had March peaks before, but this was certainly a later peak and slightly smaller peak than we'd seen in the past few years. And if you look back over the last 3+ decades, you see that most of the peaks of influenza in the United States, at least on a national level, occur sometime between January and March, a few in March, mostly in January, or mostly in February. And so last year's peak was a little later than normal, but not totally abnormally late. The other thing about last year was it was a relatively modest year in terms of severity. This is a graph of rates of hospitalizations attributable to influenza from a surveillance system that we have around the country. And what you see is the orange line that I've circled the end of there is the total cumulative rate of influenza hospitalizations in the United States compared to 5 or 4, in this case, previous years. And you see it looks pretty modest in terms of severity, much less than the last couple of years, which have been H3 dominant years before that. And it's sort of classic of what we see with H1 predominant years, which tend to infect and cause disease in non-elderly adults more so than elderly adults compared to, say, H3 disease. And in those years, we tend to have lots of disease, but less frequently severe disease. And that's what we saw in the hospitalization data. This is death data, again, pneumonia and influenza death, where the height of the red curve here over time represents a pretty good indicator of the magnitude of the numbers of deaths in the country. And again, last year, which is on the far right, compared to the 3 peaks before that, the 4 peaks before that, show that last year was a relatively mild year comparatively to some of the previous H3 and H1 years in recent times. And finally, this is a graph we show of the number of deaths among children less than 18 each year. And again, last year there were 85 deaths among children, which are about slightly less than the numbers maybe over the last couple of years. But I want folks to remember that about 50% of the deaths last year, and about 50% of the deaths every year among children that are confirmed to have flu at the time of death don't have any underlying health problems. And so this is one of the take-home messages occurring in the middle of my talk, but one of the take-home messages that I think Ms. Marotta will follow up on as well, and that is that flu carries a risk to everybody, whether you have an underlying disease or not, and therefore vaccination is clearly the best tools to prevent that. The last slide I want to show last year is this one, which goes back to the lab slide. But if you look at the inset there, and I don't think I circled it, but I'll circle it with my marker if you can see this. Right on the tail end of last year, we saw these little purple viruses. And the purple viruses are a reminder, there it is, and the purple viruses are a reminder that that we're still at risk of novel influenza A virus spread in the United States and really worldwide, and I'll come back to that at the end. Last year, like most years, we saw some swine-derived influenza viruses. In human, last year we saw 18 cases, mostly all from Ohio and Michigan. Again, reminding us, I think, of the continued threat of novel influenza A zoonotic virus transmitting to humans. Not many, but again, a reminder of that risk. That's a continuing risk, and I'll come back to that thought right at the end of the talk. So last year was an H1 dominant year. It was the second one since the pandemic. The viruses last year were pretty similar to the vaccine strains, and so we got a pretty good vaccine effectiveness as a result, which I'll go into in a minute. It was a relatively mild season overall, and it was a later season than most. So let me talk about how the vaccine worked last year, because I think this is germane to what we're going to talk about this year. I won't spend much time on it. This is a complicated slide of the vaccine effectiveness numbers that we run each year in the United States. This is for last year. And look at the overall vaccine effectiveness. Now I want you to look at the top line on the right side. The overall vaccine effectiveness last year for all viruses, for all vaccines, for all people was 47%, with the confidence intervals 39 to 53. That's about what we expect. We classically say 50 to 60, sometimes 70% effectiveness. That came in right about that. And if you look at that number by age group, you don't see much variation except in the 50 to 64-year-olds, which we saw relatively low vaccine effectiveness. But otherwise, whatever age you were, you had about the same vaccine effectiveness. The important part of last year, before that, but even with a modest vaccine effectiveness of around 50%, you see a tremendous impact of influenza vaccination in the United States. These are numbers that we're going to release today or tomorrow probably as part of National Influenza Vaccination Week. We've been doing it for the past 4 or 5 years as we think a better way to indicate the value of influenza vaccines compared with just talking about coverage estimates or talking about vaccine effectiveness. The numbers represented in this figure you have are the numbers of averted cases or outcomes attributable to the influenza vaccination program in the United States. And again, just to make it simple, look at the bottom bar. And in all ages, last year, because of the vaccine, there were 5 million fewer cases of influenza, 2.5 million fewer outpatient visits, and 71,000 fewer hospitalizations because of the influenza vaccine. And if you look at the age distribution, again, you'll see the signature of H1 disease, that most of the averted illnesses were among children and young adults, fewer among age 65-year-olds, which tend to have more immunity to H1 going into the season. But if you look over at the averted hospitalizations on the right side, you see that even though they infect and cause disease more in younger people, people who are over 65 still are at much higher risk of hospitalization than younger people, so most of the hospitalizations last year, averted and caused, were among that age group. And finally, let me show you what one of the principal stories last year was, and that is the effectiveness of live attenuated influenza vaccine this year. Again, a complicated slide, and I'm sorry for it, but look at the left panel first. These are the vaccine effectiveness numbers in each panel. On the left side of each panel is the live attenuated vaccine effectiveness. On the right side of each panel is the inactivated vaccine effectiveness. And again, the panels are for effectiveness against all viruses, H1 or the 2B types of viruses. But notice that the trend here is that last year we saw really no effectiveness or no measurable effectiveness of live attenuated vaccine compared with good effectiveness of the inactivated vaccines, whether you look at all disease, whether you look at H1 disease or in some cases B disease. But H1 was the real signal here, that it was the predominant virus last year, and the live attenuated vaccine didn't have any measurable impact on that virus, protective impact. And I won't go through this complicated slide because we don't have time, but just safe to say that our data in the U.S. that showed the lack of effectiveness of LAIV was also mirrored by similar data from the Department of Defense, which look at their dependence in the United States and also measured no effectiveness. MedImmune also did an independent study which had a higher point estimate, but still lacked significant effectiveness against H1s. And some of the international studies also showed the same thing, so some didn't. And there's interesting probably hypothesis for why there were differences in data across the world, but in fact the U.S. data uniformly showed no effect. And if you look back, this is the same sort of panel again, just looking at years in the panels instead of types. And if with the last season on the right side, then going backwards from that, if you look back over the 2 years prior to last season, we also did not see an effect of the live attenuated vaccine. The middle year, of course, was a mismatch year when we didn't see effect of either vaccine to any great extent. And so back in June, when these data were first hot off the presses, the ACIP working group and then the full ACIP convened to talk about it. We presented the data from CDC and MedImmune and other countries. We didn't expect any new data this season or prior to this season, which we have not received. And despite the variability in some of the point estimates for the vaccine effectiveness last year, it was clear that the U.S. data were consistent and clear and lacked significant effectiveness, and that the low vaccine effectiveness against the H1 viruses were also seen 2 years previously, while the inactivated vaccines worked both well, both years. And at the time, and it was clear that the cause of the low VE was not completely understood at the time. And ultimately, that led to a consensus that there was uncertainty about the effectiveness of LAIV for the coming season. So in June 22nd of 2016, the ACIP met and voted to not use the live attenuated vaccine for the coming season, but rather recommend that all people receive either the inactivated vaccine or the recombinant vaccine instead. So that's last year. Let's talk about this year for a second. We're just starting to see influenza activity this year. The inset, again, is the long tail on the right side of this curve, shows all the red viruses, and the red in this case are H3 viruses. So mostly what we're seeing are the H3N2 viruses this year. So far, at least, it's early. Know that H3 viruses tend to be associated with more hospitalizations, tend to be associated with more deaths in years in which they circulate. But again, probably too early to tell which will be predominant. Oops. There we go. Also, the viruses that we've seen so far this year are all similar to the vaccine strains, which usually mean that the vaccine effectiveness will be relatively high. And all the strains so far are sensitive to the licensed antivirals in the United States. This is the same outpatient graph, and notice the little tepid red lines on the left side, on the left lower corner, indicating that we're just starting to see an uptick in disease. I think 3 parts of the United States, mostly the southeastern part of the United States, are starting to see more disease, as well as Puerto Rico this season. I think Illinois is still classified as low, as at least last week was, so I think you're just starting to see your first cases now. And this is a map to show that. So the 2016-17 ACIP policy has a couple of big changes, or got one big change, a couple of small changes maybe. First, that we reiterated the fact that everybody over 6 months of age should be vaccinated every year, including this coming year. The big change clearly is that live attenuated vaccine, flu mist, is not recommended this year. The other big news, the other kind of big news, is that there are actually 3 new licensed vaccines this year. The Fluad, which is an adjuvanted vaccine licensed for people over 65. The cell vaccine, which is called Flu-Cellvax, cell culture rather than egg, is licensed in a quadrivalent formulation. And just a couple of weeks ago, not on this slide, was the new licensure of the Flu-Laval, the GSK vaccine, that's now licensed as a 0.5 cc dose in children down to 6 months of age. And finally, there were some changes to the egg allergy recommendations. And I'll go through those briefly in just 2 seconds, and then I'll finish. I'll say that this vaccine, compared to last year's vaccine, has one strain change. The H3N2 component of the vaccine has been updated. Not a big update, but a small update, I would say, but we should make it more closely aligned to the current strains. This is just to highlight these 2 new vaccines. I won't go through Fluad because it's licensed in for people only over 65 and not relevant to children. Flu-Cellvax also is licensed now down to 4 years of age. It's a quadrivalent vaccine made in cell culture rather than eggs, which makes it a bit different than every other formulation on the market right now. And I wanted to just make the point that with the addition of these 3 new vaccines, the influenza vaccines available in the United States this year look like this. And I couldn't fit it on the slide. It obscures the title. And just to show you that there's lots of choices out there. But the main message from CDC is that any of these vaccines are acceptable for use, as long as they're acceptable for use in the age group you're using it in. We don't prefer one vaccine over another this year. And finally, important changes to the egg allergy language. As more and more data have become available on the safety of egg-grown influenza vaccines among egg allergic kids, we've slowly loosened the egg allergy recommendations. And so now the recommendations will read that we've removed the 30-minute post-vaccination observation period. It didn't seem to offer a safety benefit because the rate of reactions was so small. Egg allergic patients can receive any licensed vaccine this year. The only caveat is that people who have severe reactions to eggs, and that is anything that's not hives, should still be vaccinated in a medical facility that is able to manage severe allergic reactions. Otherwise, any egg allergic kid can receive any vaccine that's age appropriate for them this year. So the summary is the season's just getting started. We're seeing H3s certainly now, but again, I think it's too early to see what the dominant virus will be. The vaccine's recommended again this year for any kid over 6 months of age, and that highlights the reminder to make sure that pregnant women you interact with are vaccinated to protect the kids under 3 months of age. There's growing good data to show that vaccinating pregnant women is protective in the newborn infants. And second is to vaccinate household members who are exposed to the kids under 6 months of age. Importantly, only an activated vaccine and recombinant vaccine are recommended this season. And there's lots of vaccine choices, so plenty of supply. So National Influenza Vaccine Week is a good reminder to get everybody out and get mobilized to be vaccinated if you haven't been vaccinated so far. I want to finish up with two thoughts, and I'll stop after this in 1 minute. The one thought is flu is a tricky disease, a tricky virus for a lot of reasons you know, but also that even after many decades of understanding flu, we're surprised every year by what it can do. This is a paper we published this year showing that there was an increase in parotitis cases among flu-positive patients. These are mumps-negative parotitis cases. Turned out to have flu as the cause of their parotitis. So a new clinical syndrome associated with flu that had been reported occasionally over the last couple of decades, but not in big amounts that we saw a couple of years ago. With an H3 year coming up, we might again see more parotitis cases this coming year. Second is that while we worry about seasonal vaccine rightly, or seasonal virus rightly so, we're keeping our eye every day and every week on what's emerging in terms of novel influenza A viruses. There's lots of new A viruses out there. They're causing disease, certainly in poultry and wild birds and occasionally in humans. And so we'll continue to watch those closely. If you look at this histogram I just put up, you'll see that the number of influenza A novel infections in humans has skyrocketed really over the last several years, principally because we're looking for them now. But you see that the threat will remain worldwide, and these viruses bear close attention. Finally, the good news is, while the virus threat remains, the vaccines are getting better. I've already talked about some vaccines, I've already alluded to, I guess, some vaccines that may work better in certain high-risk groups, like high-dose vaccines or adjuvanted vaccines. There are some vaccines that we're able to make faster, which would be good in a pandemic. Recombinant vaccines are a good example. We have better strategies potentially in some parts of the world to reduce disease, and we have quadrivalent vaccines which may add to the effectiveness. So incremental changes are already happening to improve the effectiveness. The big changes are yet to come. The universal vaccines that we can give not every year, but once every 3 years or 5 years or 10 years are still being worked on, and those vaccines may hopefully address more than one strain at a time, holding the promise at least of a truly or nearly universal vaccine in the next decade, but we're a little off from that. So in the meantime, get everybody vaccinated with the vaccines we have, because they're still by far the best tool we have to prevent what is a very severe disease. Thanks so much.
Thank you, Dr. Bresee. It was a wonderful presentation on the updates on flu. We'll now begin our question and answer session for the next few minutes regarding this presentation. I'm going to keep the box open, so if anyone has questions, I will just recite them for Dr. Bresee so he can answer them.
I think I talk so fast. No, no one. I think I've lost my link to the conference, my web link.
I'm going to keep on this thank you until we finish this part of the presentation. Okay. We have a few questions. Do you know if Havrix and Vacta Hep A are interchangeable?
Say that one more time. Is Havrix
and Vacta Hep A?
I do not know the answer, but I can take that to our hepatitis group to ask. I'm afraid I don't.
Okay. Is there a 2016 VIS for this year's flu?
Is there a 2016?
VIS.
There is. It should be out by now. If you haven't seen it, it's available on our website, and I can push it to the Illinois AAP. But it should be out because we've been giving vaccines for a while now. So if you don't have it, let me know, and I'll make sure I understand what's wrong.
Since pregnant mom got flu vaccine and the infant's covered till 3 months, how about 3 to 6 month window?
Yeah, I think that the 3 months is a bit of a summary estimate. I think that what the two best studies that have been done in the last couple of years, one in South Africa, one in Ghana, have found is that the protection in the first 3 months is very solid, and then you get a waning protectiveness probably for the fourth and fifth and sixth month. And so I think we're safe to say that the first 3 months is covered. The last 3 months is problematic, and I think that clearly is a high-risk window for the baby. And so we really do stress strongly that caregivers and household members all get vaccinated to reduce possible spread to that baby. That's probably the best way to protect the baby from flu, including hand washing, of course, during flu season.
Okay, great presentation. I'm an RN and get asked about how long the vaccine lasts, and is it more beneficial to get the vaccine later in the season?
It's a tricky thing. It's clear that when you get vaccinated with a flu, most of us, when we get vaccinated with a flu vaccine, you get a surge of antibodies which peak at about maybe 2 weeks or so, or 2 to 4 weeks, and then they start declining. For most people, that decline will last long past the flu exposure season is over. So whether you get vaccinated in September or vaccinated in November, you're going to be good and protected. However, there has been a concern that elderly folks that mount a less robust immune response in the first place will have a smaller peak of antibodies. They have waning too, and may be susceptible or more susceptible to disease that they're exposed to, say, in April or March. I think in the end, it's tricky to try to time your flu vaccine too carefully. While we do see an increase usually starting in November, which peaks in January to March, sometimes you get early peaks in December and start of upswings in early October. And so we recommend now that you make sure you get vaccinated by the end of October as a pretty good guide to not being too late to get vaccinated. But we really want people to be vaccinated really any time the vaccine's available in their community. We don't want to miss opportunities. And so we've been struggling over the language about how to time your vaccination to make sure you get it soon enough to get protected, but not too soon that you might be unprotected at the end of the season. But I think the data on that are pretty sketchy. And so I say get vaccinated and get your loved ones vaccinated whenever vaccine becomes available in your community, and don't worry so much about the timing.
Perfect, thank you for that. We gave a lot of flu myths last year, and the data shows flu is down from previous years. How was the data compiled to show flu myths was ineffective?
Yeah, that we do studies, we do annual studies, and we've done so since about 2006 of vaccine effectiveness studies. And the way we do it, we have 5 centers around the country, and those centers enroll sick people that come to their clinic or hospital and then test them for flu. So it's a case control study, and from that case control study, looking at the vaccine coverage among people who are flu positive versus flu negative, we get our vaccine effectiveness numbers. So we've done it pretty much the same way for the past 10 years or so. So we're very confident in our data. It's always a question of whether we have enough people that receive LAIV in the sample to measure it accurately, but this year we did, and we're confident that at least in our sample in the U.S. that the vaccine didn't prove effective. It doesn't mean it wasn't effective in every single person that got it. It just means it wasn't effective in the population that we measured.
Thank you for that answer. What is the recommended gestational period for prenatal patients?
Yeah, so we recommend now, and this recommendation has actually changed over the decades, but now we recommend that anybody who's pregnant at any stage of the pregnancy or thinking about being pregnant this flu season get vaccinated. I think there's abundant safety data on the safety of flu vaccination during pregnancy. And so really, again, not to miss any opportunities to protect a high-risk population and their baby. We want to make sure that people get vaccinated whenever they want, whenever they can. And more obstetricians are offering the vaccine in their practice, which we think is a really helpful step. As we found out that in studies show clearly that it's not only enough for the obstetrician to say you should get vaccinated. It really is compelling if they say you need to be vaccinated, and then they turn around and say, hey, I have the vaccine right here for you. And so in that setting, we see very high vaccination coverage rates. If they offer it and don't have it and say, go down the street to be vaccinated, you lose a lot of people.
Wow, thank you. That was a really great answer. I'll hold on for like another minute to see if anyone else has questions still. Okay, we have one more. Are all healthcare workers mandated?
No, they aren't. And CDC doesn't get into the mandate issue at all. We don't recommend mandates. We don't support them. We don't go against them. We don't talk about them, I guess. There are mandates, and clearly where healthcare workers are mandated to receive flu vaccine coverage, not surprisingly, is very, very high. And so they do work to get people vaccinated, but there's no national mandate for healthcare workers to be vaccinated.
Thank you. I don't think we have any more questions at the moment, but if we do, let's see if it comes after the next part.
Sure.
Thank you so much, Dr. Bresee. It was a really great presentation. All right, thank you for your questions. Now I'd like to introduce Serese Marotta from Families Fighting Flu that would like to share the story of her family's experience when her son, Joseph, had the flu. Please join me in welcoming Ms. Marotta. Serese?
Yes, there it is. I was on mute. Hello, everyone.
Don't worry.
Okay, we're good now. So thank you for this opportunity, and I'm going to share with you today my personal story about losing my healthy 5-year-old son, Joseph, to the flu during the H1N1 pandemic in 2009. So Joseph was a healthy 5-year-old boy in the fall of 2009. He had just started kindergarten, and he was actually vaccinated that year. And so this was September 2009 that he had been vaccinated. And as most of you are aware, H1N1 was not in the vaccine that year. And in our community at the time, we were living in Ohio, the H1N1 vaccine didn't come out until several weeks after Joseph passed away. So Joseph's story began innocently enough. He was riding the school bus one day. He threw up on the school bus. They called us to come pick him up, and we did so, brought him home, and throughout the day he continued to throw up and become increasingly lethargic. So that evening we made the decision that we should probably call a pediatrician, and when we did so, they urged us to take him to the local urgent care. So we did that, and when we got to the urgent care, I remember the nurse actually saying to my husband, I wasn't there, I was actually out of town that evening, but my husband telling me the story, the nurse took one look at him and said, I bet that kid's got the flu. Well, they did the rapid test on him, and that came back negative. Well, in hindsight, we know that those rapid tests at that time were not that useful, shall we say. So his oxygen levels were really low. So they sent him in an ambulance to the local children's hospital, did some testing there, and eventually diagnosed him with pneumonia that night. So the next day, I actually came home from being out of town, and he was in the ICU. They had him on all the standard medication. They had started antibiotics for the pneumonia, steroids, breathing treatments, for the pneumonia and the fact that he had some labored breathing going on. And the next day, he was actually breathing room air, so they felt that he was doing okay, and they downgraded him to the regular pediatric floor. So that was Sunday, so that was 2 days into his hospital stay. And on the regular pediatric floor, it was kind of, his condition, I would say, at that point was stable. Obviously, they were still treating him for the pneumonia. He was still on the antibiotics and the steroids, hooked up to the IV, and we had, kind of a constant stream of specialists and doctors coming in and out. A nephrologist came in to check his kidneys, pulmonologist to check his lungs, cardiologist, you name it. They all kind of came and went, and we're telling my husband and I that everything looked okay. All his tests were coming back normal. So on Tuesday, so this was several days into his hospital stay, the doctor, who was actually the chief of infectious diseases at this children's hospital, came in and said, geez, something really strange is going on with Joseph's culture. Even though the rapid test was negative for the flu and the PCR test was negative for the flu, his culture is growing influenza. And of course, we had heard about H1N1 at that time in our community, and everybody was, talking about it. And I kind of must have given him a little bit of a worried look, and the doctor said, well, don't worry, we're going to send his sample out to the CDC for diagnosis, and even if it is H1N1, it's just the flu. Don't worry, we will start him on antiviral medications. Our main concern is the pneumonia and making sure that his condition with that stays stable. So we just added antivirals into his concoction of medications. So on Wednesday, Joseph started complaining that his belly hurt. And so the doctors thought, well, let's do some testing just to make sure it's not gastritis or pancreatitis. So they went through, did some testing. Everything came back normal. And they said to me, well, chances are his belly is hurting because his pneumonia was in the lower left lobe of his lung. And they said that can be quite painful, and it could cause, pain. And that, coupled with the flu, makes sense. They said at that point in time they actually had children coming into the emergency room who they thought were presenting with appendicitis, and it turned out to be the flu. So they kind of did their due diligence with the belly pain, figured it was attributable to the pneumonia and the flu, and we just kind of continued on with his treatment. And they also added in like some Zantac and that type of thing to counteract any gastrointestinal effects that he was having from the other medication. So he had pretty much had a constant fever for several days at this point. So fast forward to Saturday morning, which was the 9th day of Joseph's hospital stay, still on the pediatric floor. And, and the whole time he's awake, he's conversing, we're watching cartoons, he's still hooked up to the IV. Not too happy about being in the hospital, but, doing okay. So Saturday morning, everything was okay. I had actually left the hospital because our daughter at that time was not allowed in the hospital because of the flu and the strict no admittance policy. So my husband stayed Saturday afternoon. I went home with our daughter. And so Saturday morning, everything's fine. Come back Saturday afternoon, and my husband met me in the lobby and said, something's going on. You have to come down here. So my husband and my daughter and I walked down to Joseph's room, and the nurses were kind of running back and forth a little bit frantically, and Joseph's blood pressure had plummeted, and they could not get a read on his blood pressure. So I think that was really the first time during Joseph's hospital stay that I was really my blood pressure went up a little bit, and I thought, what is happening here? So the doctor came in and said, okay, maybe his sodium levels are off. Something's not right. Let's take him back to ICU. So we go back to ICU. They're doing testing, and at this point it's like 11 o'clock at night. And everything's coming back normal. They're doing blood testing and poking and prodding him in x-rays and everything, and they're keeping me well informed, and I'm asking all the right questions. and everything looks normal. So my husband leaves with our daughter and takes her home for the evening. And, you know, throughout the night, it was kind of just a steady stream of people in and out. And I would say about the middle of the night, the attending doctor came in and she said, geez, we can't figure out what's going on with Joseph. His condition is perplexing. Like, I'm not especially worried, but it's really strange that we can't seem to find out what's causing the low blood pressure, and we can't seem to rectify it. So at 6 a.m. on Sunday morning, October 18th, she came to me and said, look, his respiration, his heart rate is elevated because of his low blood pressure, and just to give his little body a break, I want to put him on a ventilator. Not a big deal, again, but you might want to call your husband to have him come up, because once we put him on the ventilator, he will be unconscious. So I was calm. I called my husband, explained the situation to him. You know, and throughout the night, Joseph had been awake and talking to me. At one point, you know, he kept asking me for Gatorade, and the doctor was like, well, I don't really want him to have Gatorade, and they wanted him to drink some chicken broth. And true to Joseph's nature, I tried to get him to drink chicken broth, and he was like, Mommy, that is disgusting. I don't want to, you know, I don't want to drink it. So for all intents and purposes, we're in the ICU, and we're where we need to be, and I'm thinking, well, he's acting okay. Yes, he's sick, but everything's going to be okay. So the doctor leaves to get prepared to put him on the ventilator, and I'm standing next to Joseph, you know, and he's in his bed. And we're talking about Halloween costumes and this, that, and the other thing. And all of a sudden, he coded, and the machines went off. And I always tell people it was like a TV show, and doctors and nurses rushing in. And I backed out of the way because I thought, okay, this is serious. I need to let them do their job. And I waited in the hallway, and finally, you know, they were kind of going back and forth, the nurses were, and giving me updates. And I ended up in the room next to Joseph's, and the nurse was going back and forth. And finally, the attending doctor came in, and she was sobbing when she came in the room. And I remember I just put my hand up, and I said, you know, I asked her, did he die? And she said, I need you to come in the room with me. And so I went in with her in the room. And they were working on Joseph, giving him chest compressions, pushing up epinephrine. At this point, they had been working on him about 35 minutes. And so I think you know, that continued on for maybe 5-10 minutes. And finally, you know, the doctor stopped, and she just turned to me and said, I'm so sorry. And afterwards, we sat down with the doctor, and we had an autopsy done. And the autopsy showed that he died from complications of H1N1. And what had happened is the flu virus had gotten into his intestinal tract, eroded away from the inside out, that first part of his intestine, the duodenum, and he had suffered a catastrophic rupture of 1/4 of an inch. And that is what cost my son his life. And this was all due to the flu. And his autopsy also showed that the pneumonia had nothing to do with his death. His lungs were actually, despite the pneumonia, in relatively good condition. So I have always been pro-vaccination for my children, including the flu vaccine. And I remember I never would have guessed that the flu cost so many lives, including healthy children and adults. So it's such an important message, and that's why I came to Families Fighting Flu. You know, we are a nonprofit national organization made up of family members like myself who have either lost a child to the flu or had a child suffer serious medical complications as a result of the flu. We also have advocates and healthcare professionals that are part of our organization. Anyone that's really committed to flu prevention can be part of our organization. But the take-home message here is that, you know, my son represents any child or adult, any person out there really. You know, that CDC recommendation for everyone getting vaccinated 6 months and above, that needs to happen. And, you know, not just for ourselves, we shouldn't just get vaccinated to protect ourselves and our loved ones, but also to protect others that we come into contact within the community. So, you know, my mission at Families Fighting Flu, along with the other families, is really to share our stories, to raise awareness about the seriousness of influenza, and to stress the importance of annual vaccination for everyone. And I think what's great for you guys in the audience that are healthcare professionals, you guys represent major influencers that you can share our stories. You can share Joseph's story. You can actually go to our website, familiesfightingflu.org, and there's a lot of other family stories on there. But please feel free to share our stories when you are interfacing with patients and trying to convey the importance of flu vaccination. You guys are a really important part of the equation. And, you know, together I hope that we can all make a difference. I know we can all make a difference. So thank you for listening.
Thank you, Serese. That was a truly emotional story, and I'm really glad that you're able to share that with us.
Well,
If anyone has any questions or comments, feel free to share them.
Yeah, I just want to, while we're waiting, I want to throw out just a couple other statistics. Is, you know, on average, 100 children die from the flu every year. And, you know, even one is too many. Last year it was 87 children. And I know there's a lot of statistics out there, and sometimes I think we all can kind of get desensitized to those numbers. But, you know, the way I think about it is just last year, for example, those 87 children, that's 87 families that have an empty chair at their holiday table this year. So this is obviously something that I have a personal experience with, and I'm very passionate and motivated. But, you know, the flu kills more Americans every year than all other vaccine preventable diseases combined. So it's not just the flu, and we really need to get that message out there.
Thank you. There's been one comment. They've said, Ms. Marotta, thank you for bravely and eloquently sharing Joseph's story. Very generous of you and invaluable for us. Thank you again.
Oh, thank you.
Another comment, I'd like to thank the speaker for sharing your story with us. My heart goes out to you and your family and Families Fighting Flu.
Thank you for that.
I'm so sorry for your loss. I appreciate your efforts in spreading the importance of the flu vaccine.
Thank you.
Serese, thank you so much for sharing your story with us. I think that's all we have for today. I just hope this message resonates with everyone, and if everyone can go forward and take the flu vaccine, it could, like you said, it could save a life. Thank you so much. Dr. Bresee, thank you so much for your time as well. I wanted to thank everyone for joining today's webinar. Once again, this webinar is recorded finally, and I'll be sending an email out with a link to the recorded webinar as well as the slides. Thank you for joining, and I hope you all have a great afternoon.
Thanks, everybody.
Thank you.
Yes, Dr. Bresee?
Yeah, thanks, everybody.
Thank you.